Good morning, everyone. I'm Michael Summers. I'm a pediatric nephrologist from here in Boston at Boston Children's Hospital. I've had the opportunity to take care of patients with primary hyperoxaluria for more than 30 years now, so I'm excited about this session on primary hyperoxaluria, the road to renal preservation, and happy that you're all here today. A few housekeeping issues. First, if you haven't had a chance to download the NKF Meetings mobile app, you may want to do that. You can do your pre-test, your post-test, your evaluation, and it will also allow you to answer the polling questions. And there'll be some polling questions in both my talk and Dr. Michael's talk as well. Presentation slides are available on the mobile app and on the clinical meeting portal, depending on whether the faculty's given permission for that as well. So you may want to avail yourself of those opportunities. This session is supported by an educational grant by Novo Nordisk, and we're grateful for their support for this session. So I'm going to kick things off by talking about the epidemiology, pathophysiology, and diagnosis of primary hyperoxaluria. And then our second talk is going to be more about management and therapeutic issues. So I put this slide up here, not only because it highlights that we're actually celebrating the centennial of primary hyperoxaluria being described as a clinical entity, but to emphasize how really it's only been in about the last 35 years that there's been an explosion about knowledge, management, and now new exciting treatments for primary hyperoxaluria. And really dating from about 1990 forward. So obviously lots of information has been gained, especially in the last 15 years. Not surprising as a result that there may be sort of a deficit in the general clinical population about how you diagnose PH, how you suspect PH, how you may manage PH. I want to set the stage by going briefly through a couple cases of PH that I've been involved with. One was a girl who presented when she was 2 months old with a diarrheal illness, got dehydrated, presented to a local emergency room, was found to have severe kidney failure. She actually started on peritoneal dialysis and was kept on peritoneal dialysis throughout her first year of life. And then a subsequent ultrasound showed that she had extraordinarily calcified kidneys. And she was sent to see us here in Boston, where we were able to make a diagnosis of primary hyperoxaluria and change her management strategies. Secondly, an adolescent who had otherwise been healthy presented with several days of flank pain, and he was found to have kidney stones in both kidneys as well as nephrocalcinosis and decreased kidney function. And he was also ultimately diagnosed with PH and started appropriate management. Subsequently, he's been free of kidney stones, and his kidney function, though reduced, has stayed stable. And lastly, a young adult who got referred because of decreasing kidney function in the setting of a history of more than a decade of kidney stones with multiple urologic interventions. She finally had an evaluation that diagnosed PH1. She was found to be sensitive to something, vitamin B to pyridoxine, with her urinary oxalate levels falling, no longer having kidney stones, but was left with the reduction in kidney function that ensued until her diagnosis and treatment, and is now being evaluated for a kidney transplant. I bring these cases up because I think they emphasize certain common themes that were are important in pH. First, that the disease spectrum is really broad, so all age groups and both acute and indolent presentations can be found. The diagnosis is unfortunately often delayed, and clinical clues are either underappreciated or ignored, sometimes because of lack of clinician understanding of the disease process. And historically, we've been limited in our treatment options and their effectiveness. Now, to understand pH, you have to understand that it's an inherited metabolic condition. The problem resides in the hepatocyte with some sort of inability to maintain usual oxalate metabolism and homeostasis. So there are three primary forms of hyperoxaluria, which are conveniently labeled type 1, type 2, and type 3. The most common form, type 1, affects about 80% of individuals with pH and has to do with an abnormality in the AGXT gene, which codes a peroxyl enzyme AGT. In the setting of normal AGT levels, the substrate glyoxylate can get metabolized to glycine. But when you don't have that enzyme, you end up producing oxalate and producing really large amounts of oxalate as you go through life. Why the kidney gets involved is in humans, we excrete oxalate through our kidneys, and kidney does a wonderful job eliminating oxalate. The problem is in primary hyperoxaluria, the degree of production of oxalate is so profound that oxalate can precipitate out of the urine, causing nephrolithiasis and nephrocalcinosis. The injuries that the kidneys then suffer as a result of the nephrocalcinosis, nephrolithiasis, ongoing deposition of the oxalate, can lead to alterations in kidney function. And I show you this slide where it doesn't project as well as I'd hope, but these blank spaces are actually big crystals of oxalate. You'd see that under polarized light. Again, profound oxalate deposition, which at the end of the day leads to chronic kidney disease as you injure more and more nephrons and you go through the process of hyperfiltration injury. So PH1 is considered an ultra-rare disease. It's thought to affect fewer than 50,000 Americans. And when you look at what's actually written about PH1 in the literature, for many years it was said about 1 to 3 out of a million individuals in North America had PH1. Population analysis from the Exome Sequencing Project, the NIH, shows that we should expect about 1 in 50 to 60,000 Americans or people in North America to have PH1, which would correspond to a little over 2,000 cases in the US in 2025. In areas of the world where the gene frequency is higher, where there's consanguinity, there'd be a higher expected population of PH patients. Data that we have from registries that try to capture information on patients with stones or patients who have end-stage kidney disease kind of underscored that we're probably not picking up patients with PH very well. So data from both the NAPRITIX registries, which is a very large pediatric registry for children on dialysis or with kidney transplant, and from the Rare Kidney Stone Consortium, it's a registry for patients with inherited metabolic kidney stone issues. Both show relatively small numbers of patients with PH. Again, bringing us to the conclusion that many affected individuals are being underdiagnosed or potentially misdiagnosed. Whoops. So that brings me to the first polling question we're going to do. And that's when considering clinical clues to primary hyperoxaluria, which of the following scenarios raises the most suspicion for an actual diagnosis of primary hyperoxaluria? Is it a 3-year-old with a history of 3 kidney stones in the last year, a 12-year-old with calcium oxalate crystals on urinalysis, a 4-year-old with several episodes of cystitis and a history of what sounds like voiding dysfunction, or a 16-year-old who has an older relative who had unknown kidney failure? So I thank those of you who are responding to the poll, and it looks like we're settling on consensus with the first choice, the 3-year-old with 3 kidney stones. So if you actually look at the kidney phenotype for patients with PH, something that's really, really common is this recurrent nephrolithiasis, especially presenting early on in life. So about 2/3 of patients with PH, when you go back into their medical history, you'll get this history that they had stones, they had repetitive stones. And in a large number of patients, there can also be this flavor of kidney dysfunction going on. This data from North America looked at presenting symptoms at PH diagnosis. So what actually led individuals to seek out further care and led to their diagnosis. And again, you can see that about 3/4 or 2/3 of the patients had stones, nephrocalcinosis, or a combination of those. When you actually look at when these patients present, it's very common for there to be a childhood diagnosis. And in fact, showing up during infancy can also be seen and can lead to some of the most profound consequences of primary hyperoxaluria that we're going to talk about in a bit. As I've alluded to, end-stage disease can be common, and the diagnosis is often very delayed. This data from Europe shows that the median age of diagnosis in their registry of patients with primary hyperoxaluria was 8 years of age, with about 1/4 of the patients being diagnosed as adults. Again, similar to what I shared with you about North American data, this European data found that about 70% of the patients were diagnosed after they had had symptoms and been followed by a medical professional for these symptoms for more than a year. Oxalosis is the term that's given to individuals with primary hyperoxaluria who have multi-organ involvement from their oxalate deposition. So we've talked about the kidneys being involved with stones and nephrocalcinosis, but unfortunately, it's a multi-organ disease, and you can see deposition of oxalate in bones, in eyes, in the heart, in vasculature, thyroid, skin, muscle, all over. And this deposition in some patients, again, can be very, very significant and marked. So, a horrible number of kidney stones, marked orthopedic abnormalities, blood vessels with really bad oxalate deposition as well. And one of the most serious and feared consequences is actually oxalate deposition in the retina, which is seen most commonly in individuals with very poor kidney function who have prolonged levels of high plasma oxalate levels. This is the retina of an individual who'd been kept on dialysis for about 8 years, and you can see how he developed these irreversible retinal depositions of oxalate. Now, kidney failure exacerbates this systemic consequence of primary hyperoxaluria. So I talked about the kidneys being really good at excreting oxalate, but what happens as your GFR falls, and especially as your GFR falls to less than half of normal, gets to the 30-40 range, then your level of plasma oxalate in your blood starts to rise as your kidney can't excrete the oxalate burden as well. So normally plasma oxalate levels are quite low, less than 2. But as your GFR falls, especially as it gets to the range of 30 or less, then your oxalate levels will increase. As you get to oxalate levels above 30, then you're at great risk for accelerated deposition of oxalate systemically. Not that it's not happening prior to that, but especially as you reach that level, that's when you're most at risk of ongoing systemic oxalate deposition. when you look at end-stage kidney disease and whether it's present or not at pH diagnosis, again, it's not surprising for us to see that the data shows that if you're able to be diagnosed younger, you're less likely to be diagnosed when you have end-stage disease. So if you're less than 18 years of age, this data from the European registry showed that 2/3 of the patients diagnosed in childhood or adolescence still had some residual kidney function. On the other hand, the older you are with diagnosis, the longer you've had oxalate injury to your kidney or systemically, the more likely you are to be diagnosed with little effective kidney function. Over the last 20 years, as the genetics of primary hyperoxaluria have been explored and refined, we've learned that the time of loss of kidney function is linked to the genotype, so the type of mutation you have. So with PH1, we have a mutation in the AGXT gene. More than 200 mutations have been described so far. Mutations can be null mutations with none of the enzyme produced, or missense mutations where some of the enzymes produced but can't be used as effectively. You can see in this diagram that shows survival based on genotype that patients who had this tan-colored gene, the red gene over here on the right, seem to do better in terms of long-term kidney function before they reached end-stage kidney disease. And this is linked to the presence of them having a G170R mutation. The importance of that mutation is that those patients have sensitivity to pyridoxine, so to vitamin B. Pyridoxine helps to stabilize the AGT that these patients produce. So with this mutation, AGT can be produced, but it's mistargeted. It doesn't go to the right cellular compartment. But pyridoxine helps to increase the enzymatic strength and improves its delivery to the right compartment so that patients with these types of mutations treated with pyridoxine can reduce their pathologic oxalate production and excretion. And it can be a relatively effective therapy in those patients who have a high degree of pyridoxine sensitivity. Unfortunately, many patients who have pyridoxine sensitivity will only be able to reduce their oxalate production by 25, 30, 40% and not all the way. So they'll still have consequences of their oxalate production over time. In terms of survival in PH patients, you can see that the survival curve over time lags from what you'd expect in a general population or a healthy population. But again, what's more concerning is that patients who have end-stage disease with PH, their lifespan are the ones that are being effective. So you can see in red patients with PH who maintain their kidney function and that their survival is relatively good. But it's the patients who develop end-stage disease and the consequences of their end-stage disease magnified by the consequences of their systemic hyperoxaluria that leads to this steady loss of life at an accelerated rate. This can also be seen when you're on kidney replacement therapy. So this graph looks at the survival of patients on dialysis without primary hyperoxaluria in the dotted line and compares it to survival of patients with primary hyperoxaluria in the solid line. And you can see that within a short period of time on dialysis, the curves start to splay and that the patients with primary hyperoxaluria are already manifesting lower survival. So all of this information, again, shows why it's so important for us to be able to know who should we suspect who may have primary hyperoxaluria, and also how we go about diagnosing hyperoxaluria. So in terms of the high-risk clinical clues for a primary hyperoxaluria diagnosis, from the information I've shared already, you can glean that having a history of nephrolithiasis, nephrocalcinosis, repeated nephrolithiasis, especially these problems showing up early on in life, leads you to have a high index of suspicion of potential PH. And any individual who has reduced kidney function or end-stage disease in a history, with a history of concomitant stones or past history of stones, needs to fall into this category as well. In terms of diagnostic evaluation, most people would recommend starting out with measuring your urinary oxalate excretion. Now, this can be done by a 24-hour collection or a spot sample where there are normed values based on age. For the 24-hour collection, if you happen to be assessing a child, it would be important for you to make sure that you're norming this to surface area. Brings us to the second polling question. So we have a 10-year-old with a history of several kidney stones, and urinary oxalate levels have been found to be high. So to make a definitive diagnosis of primary hyperoxaluria, would that be best done by genetic testing, kidney biopsy, plasma oxalate levels, or kidney ultrasound? Right. Again, we're seeing consensus around genetic testing, which is indeed correct. So we've talked about there being hundreds of mutations with the AGXT gene and how they shake out into causing different issues with the enzyme. But what's been different in terms of genetic diagnosis in the last decade is the increased availability of genetic testing. So really testing for genetic mutations with PH has moved from the research realm being costly, being potentially cumbersome to do, to being readily accessible on commercial panels with a great reduction in costs and in the testing being done, and marked improvement in turnaround time, so that generally within a few weeks you can know whether your patient may have a PH mutation or not. This certainly facilitates definitive diagnosis. I'm often asked about plasma oxalate levels, and as I mentioned to begin with, in the setting of good GFR, your kidneys are excreting oxalate so well that your plasma oxalate levels will stay low. But it's only in the setting of your GFR falling, especially to less than half of normal, 40 to 30, that you start seeing oxalate levels in the plasma increase significantly. And again, remember, we're most worried about those levels that are going above 20 or 30, them leading to systemic deposition of oxalate. Dr. Michael's going to share with you some of the new ways we may go about treating primary hyperoxaluria, which would underscore kind of the diagnostic importance of genetic testing. So we've covered how PH1 is an inherited disorder of oxalate overproduction. It frequently leads to kidney failure and to systemic oxalosis with fatal consequences. PH1 frequently presents early in life, but it can present in individuals of any age, and there's often a significant lag between the symptoms at presentation and diagnosis. This lag comes about because there's clinician ignorance of PH1, its manifestations, and how you go about a diagnostic evaluation. So it's especially important for there to be more education, especially to primary care clinicians, urgent care and ED clinicians, to urologists who may be seeing these patients with recurrent stones or with stones, for them to understand who the high-risk patients are and who should be referred to nephrology for further management. And although initial evaluation for pH relies heavily on urinary testing for oxalate, with increased availability and precision of genetic testing, it's being used to make the more definitive diagnosis. So, thank you, everyone, for your attention. I'm going to hold questions on this part until after Dr. Michael's been able to speak as well, and then I think we'd be able to have questions on both pathophysiology and management. So I'm going to introduce Dr. Minnie Michael. Dr. Michael's Associate Professor of Pediatrics at the Baylor College of Medicine, where she also helps to direct their kidney stone clinic. She has extensive clinical experience, is a great clinician educator, plays a major role in training of pediatric nephrology fellows at Texas Children's Hospital. She's been an investigator in numerous multi-center studies, including studies in primary hyperoxaluria, and has held leadership positions in several professional organizations, including the American Society of Pediatric Nephrology and the Oxalosis and Hyperoxaluria Foundation. So thank you, Minnie, for coming to talk with us today.
Okay, thank you for inviting me to give this talk. So I will be covering the update on treatment strategies for PH1. These are my disclosures. Just quickly reviewing my learning objectives are early treatment and kidney damage prevention in patients with PH1, review of PH1 clinical trials, and transplantation options and outcomes in PH1 with advanced CKD, and investigational therapies. So coming to early treatment and kidney damage prevention, let me first review the standard therapy. As Dr. Sommers said, until recently, the standard therapy was mainly supportive care with high fluid intake, up to 2 to 3 liters per meter square per day, aiming at urine dilution by day and night, and crystal inhibitors to prevent the precipitation of calcium oxalate. Commonly used agents include potassium citrate and magnesium oxide. And a trial of high-dose pyridoxine or vitamin B6, a coenzyme of AGT that promote the conversion of glyoxylate to glycine, is indicated in all patients who at the diagnosis of PH1. As Dr. Sommers alluded, there are certain mutations that are associated with the pyridoxine responsiveness. About 30 to 50% of patients with PH1 will respond to pyridoxine therapy. A trial of pyridoxine that lasts for at least 3 months is warranted in all patients with PH1, and response is defined as more than 30% reduction in urine oxalate level. And the pyridoxine should be continued if confirmed to have pyridoxine-sensitive mutation or if there is complete or partial response. Some patients may progress to end-stage kidney failure or be presenting with kidney failure. They would require intensive hemodialysis and eventually sequential or combined liver-kidney transplantation. So before going to novel therapy, let's review a polling question. What is the primary cause of kidney failure in primary hyperoxaluria type 1? Hypertension, oxalate crystal deposition. Okay, looks like you all got it right. Oh. Okay, majority got it right, oxalate crystal deposition. Before going on to novel therapy, let me quickly review the glyoxylate metabolism and the enzymes of interest. As Dr. Summers indicated, primary hyperoxaluria type 1 is due to mutation of AGXT gene coding for AGT enzyme, resulting in overproduction of oxalate. I also want to point out two other enzymes which are going to be the targets of therapy. Glycolate oxidase, which convert glycolate to glyoxylate, and then lactate dehydrogenase, or LDH, which convert glyoxylate to oxalate. So as we all alluded, treatment landscape for PH1 has changed dramatically by availability of ribonucleic acid interference agents that reduce substrate for oxalate production. Lumasiran inhibits the production of glycolate oxidase, or GO, by cleaving HAO1 mRNA. And Nedosiran inhibits the production of L-lactate dehydrogenase by cleaving LDHA mRNA. So we have two approved novel agents, or RNAi agents, for treatment of PH1, lumasiran and nedosiran. Lumasiran was approved in November 2020 for PH1 for all age groups, including those on dialysis, and it's administered subcutaneously. And the dosing is initially loading dose given on monthly basis for 3 doses, followed by the frequency depends on the age. If it's less than 10 kilogram, it's monthly, and every 3 months if patient is more than 10 kilogram. Nedosiran was approved in September 2023 for PH1 patients, initially only for 9 years and over, with the eGFR of more than 30 ml per minute per 1.73. But as of March 28, 2025, it is approved for children more than 2 years of age with eGFR of more than 30. Nedosiran is also administered subcutaneously, and the dosing is monthly, and dose is based on actual body weight. You can refer to the package insert for the actual dosing. So now let us review the clinical trials. First, I would like to review lumasiran trials. They are called Eliminate trials. There are 3 trials, and all are phase 3 multinational trials, including genetically confirmed PH1 patients. Eliminate A trial is a pivotal study with a 6-month double-blind placebo control period and an extension period up to 54 months. Inclusion criteria were age more than 6 years, eGFR more than 30 ml per minute per meter square, and 24-hour urine oxalate excretion of more than 0.7 millimole per 24-hour per 1.73. Eliminate B trial was an open-label, single-arm study with the extension period up to 54 months, and inclusion criteria children aged less than 6 years, urine oxalate to creatinine ratio of more than upper limit normal for age, and eGFR of more than 45 ml. Eliminate C trial was a single-arm study of all ages with the extension period, and all patients should have plasma oxalate level more than 20 micromole per liter and eGFR less than 45. If the patient is more than 12 months, and if under 12 months, increase serum creatinine. And there are 2 cohorts. Cohort A not receiving hemodialysis, and cohort B was receiving hemodialysis. So quickly reviewing results of Eliminate A trial, they enrolled 26 patients, were assigned to lumasiran group and 13 to placebo group. And the primary endpoint was a % change in 24-hour urine oxalate excretion from baseline to month 6. This graph shows the pink line is the placebo group and the blue is the lumasiran group. And the dotted line is the 6-month mark. As you can see, there was reduction in 24-hour urine oxalate level in the lumasiran group of 66.9% at month 6 and At month 60, that's the end of the study, there was 54% reduction. The placebo crossover group, that's placebo lumasiran, had 56% reduction of 24-hour urine oxalate at month 54. Clinical outcome data were also encouraging with a stable eGFR and improved plasma oxalate levels, improved kidney stone event rate, and improvement or complete resolution of nephrocalcinosis. And there were no safety concerns. Most common lumasiran-related AEs were mild injection site reactions. Eliminate B also had similar results, enrolled 18 patients, and the primary endpoint was a spot urine oxalate to creatinine ratio from baseline to month 6. And as shown in this graph, mean % change in urine oxalate to creatinine from baseline was 76% at month 6, and it was maintained at 74% at month 60, and that's the end of the study. And the mean percentage change of plasma oxalate from baseline was 30% at month 6 and sustained at month 60. eGFR remained stable through month 60, and the kidney stone event rates remained low through month 60. Of the 14 patients with nephrocalcinosis, grade resolved in 71.4% at month 60. There were no safety concerns. Eliminate C trial included in cohort A, they had 6 patients, though they were not on hemodialysis. And I can see in the Eliminate C trial, because of the low GFR, plasma oxalate is the outcome measure. So primary endpoint is the % change in plasma oxalate from baseline to month 6. And the cohort B had 15 patients who were on hemodialysis. And primary endpoint was the % change in pre-dialysis plasma oxalate from baseline to month 6. And this graph shows, again, blue is cohort B and the pink is cohort A. Cohort A had mean % change of plasma oxalate reduction by 33% at month 6. And cohort B had mean pre-dialysis plasma oxalate change was 42% at month 6. We also looked at the absolute reduction in plasma oxalate. In cohort A, mean plasma oxalate decreased by 60.5% at month 24. And cohort B, mean pre-dialysis plasma oxalate decreased by 30.6% at month 24. Just now going to Nedosiran trials. They are called Hyperoxaluria trials. Nedosiran trials, Hyperoxaluria trials, actually, Nedosiran was studied for all types of PH1, PH2, and PH3. But for this talk, we will only be reviewing the PH1 results. So the main trial was a Hyperoxaluria, which was a double-blind, placebo-controlled study, including 35 patients, of which 29 were PH1 and 6 were PH2. And they were randomly assigned by 2:1 to Nedosiran group and placebo group. Including patients' eGFR at inclusion was more than 30 ml per minute per 1.73 meters square, and 24-hour urine oxalate excretion of more than 0.7 millimoles per 1.73. The primary endpoint, again, is % change in baseline 24-hour urine oxalate excretion. Here they assess by area under the curve from day 90 to 180. As you can see in the graph, blue line is the placebo group, and green line is the treatment group. And as you can see, there was significant improvement in the urine oxalate level, and the effect was sustained by the the shaded green area, which indicate the area under the curve. They did a subgroup analysis of PH1 and PH2 patient, and the PH1 is indicated by the green line and the PH2 as the light blue line. As you can see, there was significant improvement in the urine oxalate level in the PH1 group. There was 81% had normalization or near normalization of urine oxalate at 6 months. There was no significant effect on PH2 patients, and the nedosiran was well tolerated with no serious AE. All patients rolled over into the ongoing long-term extension study. So FIOX3 is the open-label extension study, which is lasting for 4 years and enrolling all PH patients with the eGFR of more than 30 ml per minute per 1.73 meter squared. And this is a 9-month interim analysis of PH1 patients. As you can see, blue is the placebo group and the green is the treatment group. At 6 months, when placebo group were crossed over to nedosiran, was indicated by the dotted line. The reduction is observed regardless of baseline urine oxalate entering FIOX2 or FIOX3 for placebo nedosiran group. And urine oxalate levels were at normal or near normal levels in both groups at 9 months. There were no safety concerns. And then this is another extension analysis at 42 months. And as you can see in this graph, mean 24-hour urine oxalate excretion declined by more than 60% and remained stable from month 4 to month 42. Mean eGFR remained stable till 42 months. Annualized stone event rate decreased significantly, and nedosiran was also well tolerated. Most common known serious treatment AEs were injection site reactions. FIOX8 is a phase 2 trial of nedosiran in pediatric patients with PH1 with relatively preserved kidney function, including pediatric patients between 2 and 11 years of age with maintained renal function. And as you can see, urine oxalate to creatinine levels reduced by 64% on average at 6 months. And plasma oxalate reduction was also significant, and eGFR remained stable, and nedosiran was well tolerated. FIOX7 is an ongoing study, including both PH1 and PH2 of all children and adults with the GFR less than 30, including those on dialysis, and plasma oxalate more than 20, and the study is ongoing. So now we have another polling question. Which of the following best described the therapeutic goal of lumasiran or nedosiran in treating primary hyperoxaluria type 1? Okay. Mm-hmm. I think majority got it. Majority opinion is to reduce the urine oxalate level, which is the correct answer. That's the goal, to diagnose early so that we can reduce the urine oxalate excretion. So going from that question, eGFR outcomes from the trials and lessons learned. So the eGFR outcomes in Eliminate A and B trials. Eliminate A trial, you can see the eGFR maintained from study entry to the end of the study in the same range. And Eliminate A, mean age of the patients were actually 15 with a range of 6 to 61. So as you go older, your GFR will be higher when you start, and that's what's maintained till the end of the study. Eliminate B trial had, as we saw, they were young children. Mean age was 51 months, and their GFR at start was good, and that was maintained. eGFR outcome of nedosiran or FIOX3 trial at 42 months was maintained throughout the study from 71 to 81.5 ml per 1.73 meter square, and the mean age of PHEOX3 trial was 24 years. So eGFR at long-term follow-up in both Eliminate and Nedosiran trials depended on the initial eGFR, and hence it's important to start treatment early. So coming to transplantation options and outcomes for PH1 with advanced CKD. So from Eliminate-C trial, 5 of the 15 patients from cohort B who were on hemodialysis underwent isolated kidney transplant as of month 36. And the transplant decisions were made at the discretion of the individual investigators. All 5 patients had reductions of plasma oxalate prior to transplantation, and all 5 patients at isolated kidney transplantation remained dialysis-free, had no oxalate nephropathy, and continued on lumasiran treatment. So for best practices for management of PH1 with or without advanced CKD, you can refer to 2 recent publications of clinical practice recommendations by European Rare Kidney Network and Oxal Europe. And the second one was published here in the US by the experts, guided by OHF. And the second publication actually focuses more on the management of dialysis and transplantation also. So from that, we look at the combined liver kidney transplantation is still the option when there is no access to RNA agents or absence of pyridoxine responsiveness. And sequential or combined liver kidney transplantation can be considered depending on local resources and expertise, as similar rates of patient and graft survival was observed. The kidney-only transplantation is an option if you're receiving RNA agents or full pyridoxine responsiveness. There are successful reports of kidney-only transplant while on lumasiran. And I want to share one case where I was part of, I was consulted at the diagnosis of this patient. And I would like to acknowledge Dr. Cheyenne Wu for sharing the details of this case from Buffalo University. So this is a Caucasian female who is now aged 3 years. She first presented at 3 months with vomiting, facial edema, and found to have elevated serum creatinine up to 6. So we saw the presenting symptoms. So the patient actually had kidney biopsy, which showed oxalate crystal. That's when she contacted me. And the hemodialysis was started on the 3rd day of presentation. And the PH1 diagnosis was confirmed by genetic testing. Lumasiran was started after genetic confirmation of PH1, was about 6 weeks later. And peritoneal dialysis was added 3 months after presentation to optimize the plasma oxalate level. And she was eventually referred to UPMC for transplant evaluation. So she received live donor kidney transplant from her mother at 14 months. Now she's 3 years old, and she is 17 months post-transplant with functioning graft. Functioning, as you can see, after starting Oxlumo, and then she had the transplant, and there was significant, actually her renal function is normal, and she continues on lumasiran as normal urine oxalate level. So now we will quickly review the investigational therapies for PH1. There are some ongoing trials with the agents that inhibit hepatic enzymes. Stiripentol is an anticonvulsant drug that inhibits neuronal as well as hepatic LDH to reduce oxalate generation. A trial is underway to evaluate efficacy and safety of stiripentol in patients more than 6 years with all types of PH. CRISPR gene editing is a very promising therapy. Gene editing of HAO1 gene coding for GO has been developed in animal model using CRISPR-Cas gene editing technology. HAO1 gene editing has been performed in primates and is being advanced to study in a clinical trial. So phase 1 and 2 study of ABO-101 in primary hyperoxaluria type 1, it's called REDEFINE, is underway by Arbor Biotechnologies. Another one is an oral small molecule targeting GO inhibition is currently in phase 1 trial. And also an oral LDHA inhibitor is currently in phase 1 trial. Other agents that have been tried are Oxalobacter formigens. Is a degrading intestinal is supposed to work through degrading intestinal oxalate and enhancing oxalate secretion from blood to the intestine. However, did not show the phase 3 trial did not cause a significant reduction in plasma oxalate over 12 months. But Oxbact may have a beneficial role in preventing kidney stones. Another agent is lanthanum. The targeted release capsules containing 500 milligram lanthanum carbonate, which is supposed to be released to the distal part of GI tract, was studied in 4 patients and showed effective reduction in urine oxalate. Further studies are needed. In conclusion, treatments for primary hyperoxaluria type 1 is evolving with approved agents like lumasiran and indosiran. Early diagnosis of PH1 is important for targeted therapies. These new treatments will potentially reduce the incidence of end-stage kidney disease in PH1 and eliminate the need for liver transplantation for PH1 in the future. We'll come to the questions.
If there are any questions from the audience, if you can come up to the microphone. Minnie, there's a question about, you mentioned hyperhydration and crystallization as kind of standard therapies. And how are the novel therapies potentially changing that? Do you still need to continue to use those, is I think the question.
Yeah, initially when a diagnosis, you need to do all the supportive care, including hydration and crystal inhibition. But once you have the urine oxalate levels more in the normal range consistently, then you can slowly kind of wean them off. But another thing, you also have to look at other stone risk factors. I actually have a patient who has very low citrate level. So even when the oxalate level is normal, his citrate level is still low, so which is another risk factor for kidney stones. So I maintain him on potassium citrate still.
There's another question about the novel therapies, the RNAi therapies, and their use. Should the drugs, would you ever consider stopping the drugs once the oxalate levels are normal or near normal? No. Then how often should you monitor like the urine or blood levels of oxalate over time?
Yeah, this treatment has to be indefinite, and so you can, once you have normal levels, and you could reduce the frequency of checking to every 6 months. Initially you should be checking more frequently, at least every 3 months, and once you have normal levels, 2 or 3 normal levels, you can space it out.
And there's a final question through the Q&A. Again, a good reason to download the app if you haven't downloaded the app. But what is the recurrence rate of kidney stones leading to end-stage kidney disease with PH1 after kidney transplantation? So that's an interesting question, because obviously, as Minnie shared with us, if we're effectively blunting the oxalate production with RNAi therapy and going to kidney transplant, then you'd expect the oxalate production to continue to be low, and the patients wouldn't necessarily be at risk of kidney stones. But some patients, because of the systemic burden of oxalate they've seen prior to diagnosis or prior to effective therapy being started, remember how I talked about you deposit oxalate all over your body. Well, then, once you've blunted the overproduction of oxalate, what happens is oxalate can leach out of those deposits into your systemic circulation again. And so it is important in patients who you transplant with PH1 to at least start out measuring their urinary oxalate levels to see if they're high or not, because some of these patients can have quite high urinary oxalate levels as they mobilize things, and they would be at risk of stones. But what you'd expect from what Minnie showed you and from what seems to be the case in the patients who are being followed in these extension studies is that over time, their levels of urinary oxalate fall as well, and they shouldn't be at risk for kidney stones more than any other transplant patient.
So maybe I can add one thing. So with those patients, when you're doing dialysis after transplant, depending on the prompt function, whether the graft if the graft function is promptly there and good urine output, generally you don't, the oxalate level will come down. But if there is a delayed graft function, these patients would need transplant dialysis. So especially if the oxalate level is really high. So some of them might need a few days of dialysis or CRRT or continuous renal therapy.
Great. Well, thank you everyone for your attention and for coming to this session. Again, if you want your CME credit, remember to do the pre and post tests. You can do that in the app. And we'd welcome your evaluation of the session in the app as well. Thank you.
Thank you.